intratympanic cisplatinum ototoxicity prevention.
It's such a big screen, I don't need readers, I think, almost. That's good. All right. Well, thank you. Herb, Jack, thank you for inviting me. Herb, I think I've known you my entire career, since I was an intern when Gene Myers introduced us, and we've had great interactions throughout my career, and I really appreciate all the work and the help that you've given me, and so I'm happy to be here and honored. I'm going to talk intratympanic, some things that are new. All right, so Dan presented some great new things that are coming forward, not yet available to everybody. This is sort of the same thing, but these are the things that are on the horizon, right? You know, cisplatin ototoxicity is a huge problem. We'll talk about that. We'll talk about some studies that are looking at this now clinically. I'll give you one slide because Dan did such a great job of the OTOF. And then I'll show you something else that we're working on as well with autologous cartilage ears now being grown and starting to be used for microtia repair. So first thing is this was developed by Decibel. It's a cisplatin ototoxicity prevention. And I'll go back. No. So one thing, it was on the original slide for my title slide. In disclosure, I am the chief medical officer for a company called Origin. I was the chief medical officer for Decibel. They were bought out by Regeneron, and I still consult for them quite frequently in what we're doing. And also I'm at Boston University. So cisplatin is still used regularly in the treatment of cancers. We all know this. And even though they try to bring a lot of other agents to replace cisplatin because of all the toxicities, nothing seems to work as well as cisplatin. And we know this, and even though we're ears, we use it all the time in head and neck. Our colleagues are always using this. All right? But frequently, it has problems with ototoxicity. And this can be hearing loss, it can be vestibular, it can be your ability to understand sounds. And in adults, there is currently no treatment available in order to prevent it. Now, in the pediatric, in solid tumors, in liver, there's a company that developed an IV thiosulfate that can be given in order to prevent ototoxicity. The problem is that thiosulfate chelates cisplatin. Well, that makes it ineffective. And so in order to give it, you got to give it a long time after the chemotherapy was given, about hours, almost up to 6 hours. And because of that, it loses some of the effectiveness that it can have for ototoxicity. So it isn't all that great. So what else could be done? Well, we've just heard now, Mike gave a great talk about intratympanic and other sorts of small molecules that could be used. Heard about gene therapy. You can actually now develop, and what Decibel developed was a proprietary formulation of sodium thiosulfate. So sodium thiosulfate is not new, been around forever, but getting the right components to be able to come across the round window membrane, to stay and stick and make sure that most of it does get into the inner ear in order to prevent the cisplatin from attacking the cells, that was the key. And so when you do these studies, you always got to make sure that it's safe and that nothing untoward is going to happen to patients, right? So the first thing, once you have your product, is you do a phase 1 trial in healthy volunteers to make sure that everything works. And this was done. And the main thing is you want to make sure that this intratympanic injection is not getting absorbed systemically in order to negate the effects of the cisplatin on the tumor. And so this trial had 42 patients, and you can see on the top there, you have to get above about 30 in order to have an effect. And way down here, about 30 minutes after the injection, you got a little bit of a blip here, and then it's all gone. So really, there should be no effect systemically about an intratympanic injection on having an effect on the cisplatin's ability to kill the tumor. Once you have your safety, you can start doing a phase 1 trial on your human subjects. Usually those trials, you have to figure out what dose you're going to use. And so the two doses are 12%, 25%, weight by volume. That'll be injected into the ear. In this particular case, we're perfect. We have 2 ears. So one side gets an injection, the other side doesn't. That's your control. All right, they get a placebo injection into the untreated ear. That way, everybody's blinded. Nobody knows what they're getting. Now, in that trial of 19 patients, almost all the patients had head and neck cancers. It was well tolerated. There was a little bit of ear pain initially on the injection on those that received the thiosulfate. The reason is that the pH is a little bit acidic, so you do get a little bit of burning sensation. It dissipates within about 15 minutes. The interesting thing was the ears that were injected with this, complete protection in over half, significant partial protection in another third. So basically, 87% of the ears treated showed protection against the cisplatin. In this slide here, you can see that, yes, you may have gotten some loss, but you're still got pretty good hearing. Whereas those that had ototoxicity and only got the placebo, their average loss was pretty significant, more in the moderate range. The other thing is that for those patients that had ototoxicity, and what we found was that was over 80% of all patients. In the literature, studies will show 60 to 70% get ototoxicity. Here it was a little bit higher, but again, just demonstrating that good protection, but better protection when you gave the higher dose. So 88% of the patients experienced ototoxicity in the placebo-treated ears. We didn't see any real systemic effects from it, and 87% of those 88% were partially or completely protected from ototoxicity. This will start to go probably into a phase 2 trial. The thing that you should know about this, the thing that we were all concerned about, was that, boy, this is hard because you got to do this before every time that they get a cisplatin dose. All right? And so someone has to go over, inject their ears, and be able to help them, right? Is that something that's going to fit into our practice? I don't know. If somebody told me that you could save hearing, I think we got to figure out a way to do it if this works. And from a phase 1 trial, it certainly does, but we'll see on phase 2 and phase 3. But I think this is going to really offer patients a very, very good solution. I'll touch on this just real quick. Dan did this. What I'd like to show this one here. So Decibel did implant a 2-year-old as their first patient. So somehow they got a little bit different. They were able to, convince that they could go a little bit earlier. And in 12 weeks, you can see that the hearing is, substantially gone from here all the way up, and I know for a fact that it's gotten even better over the last time. Another one was just implanted. So it is moving forward. And at ARO, there was a Chinese group that also presented their work, which is basically the same thing that Decibel has, because that's where where some of the studies were done. And they also demonstrated excellent results. So in echoing of Dan's talk, it's coming. How long it's going to take or anything like that, but I think gene therapy is going to be within our lifetime. And then finally, just to let you know, there is something you may hear about. Your patients may start asking you about it. If you take care of children that have microtia, maybe you do BAHAs, and they're looking for solutions. This company has got a phase 1 trial that started. There's already been a number of children that are now having their ears being grown. So basically what happens is you take a piece of cartilage from a good ear, you macerate it, you start to grow those cells. Once they get to a certain number, you're able to add a little bit of polymer to make it a little thicker and print a brand new ear for them, 3D. You let that grow till it hardens up enough so that it can withstand all the pressures. You implant that instead of taking a rib graft, instead of putting a piece of plastic in the ear that will never integrate into the body. It's their own tissue, it's their own cartilage cells. And that will allow you to have hopefully, a new autologous ear. So if your patients start asking you, or you get somebody that asks you, know that trial is ongoing. All right, that's all I have. Thank you.
Thank you, Pete. Steve Cass comes back from Denver, Colorado. And Steve is going to talk about airborne gaps in superior canal dehiscence. Not all conductive hearing loss is otosclerosis.
Jack, thanks for inviting me back. And Herb, I also met you when I was a resident. And I like to think I've read most everything you've ever written and published. So you had a big impact on my career. And I really respect all the work you've done and for our field and for myself in particular. So congratulations. Today I want to talk about how airborne gaps can be a troubling condition in terms of diagnosis. We all see a normal ear and we see an airborne gap and we think otosclerosis. And I feel like our residents get trained into knowing like one cause of a conductive hearing loss, and that's otosclerosis. But as we've, over the last 20 years, gotten to know superior canal dehiscence more and more, it's clear that superior canal dehiscence can mimic otosclerosis, and it present with an audiometric pattern with an airborne gap that suggests a middle ear condition. And if you don't have an open mind to other conditions or have a differential for that conductive hearing loss or that airborne gap, you can be led down to the path of thinking that this is otosclerosis. To make the problem a little bit more troublesome for me is that not all patients with superior canal dehiscence will have vertigo or sound pressure or vibration sensitivity, or they won't realize they have it. Maybe they've had it all their life and they just think that's normal. So I've definitely had the personal situation where patients have told me they have none of these symptoms, but they have superior canal dehiscence. And then when you start talking about it, they're like, oh yeah, I do have that. So these symptoms can be absent and then give you more difficulty in making the correct diagnosis and doing the right procedure. These concerns these are examples of the airborne gaps you can see in superior canal dehiscence that are published in the literature. And the grouping here on the left is from Harvard and then from Hopkins. And you can see that those airborne gaps are pretty significant. And they're in the low frequency range where we would often see airborne gaps from otosclerosis. Sometimes there's a complex pattern with sensorineural hearing loss in addition to it, but certainly it's enough for us to be concerned about it mimicking a pattern that you would think is otosclerosis. So this prompted me to want to look into it a little bit deeper. Can the patient history really help you distinguish between an airborne gap due to otosclerosis and one due to superior canal dehiscence? What about stapedial reflexes? Clearly, they should be absent in otosclerosis and present in superior canal dehiscence, but how often are they done? Do we go to surgery without them being done? And then it raises the question of whether or not a CT scan should be done prior to surgery for conductive hearing loss. And I sort of grew up thinking you would never need to do that, but more and more I see our colleagues ordering CAT scans routinely now. Often they might have a CT scanner in the office. It makes it easier. And should that maybe be more of a standard that we follow? So to help answer some of these questions, decided to look at all the patients that were diagnosed and treated for superior canal dehiscence and otosclerosis at the University of Colorado over a 10-year period. And this included 661 patients who had stapes surgery and 74 patients who had surgery for superior canal dehiscence. And this work was done with the assistance of Renee Benakis-Hartle and Alex Kaiser as a statistician who helped us at the university. So this is a nice summary of the data that we found. First of all, there was no real significant difference in male or female preponderance. There was, interestingly, a large difference in the presence of migraine as a comorbidity more often in superior canal dehiscence patients than in otosclerosis patients. Maybe patients with otosclerosis are protected from migraine because that number of 5.3% is actually lower than the natural rate for migraine. Basically no difference for diabetes, and there were several patients who had a family history of otosclerosis. When we looked into the case history, it was common to see tinnitus reported in both groups of patients, from about half to 60% of the patients. When we ask about pulsatile tinnitus, that's where we start to see a big difference. It's pretty rare in otosclerosis to have pulsatile tinnitus to be a symptom that the patient would report or admit to, but it's very common in superior canal dehiscence, as we know. Dizziness is also an important factor because in otosclerosis patients, it is really not that common. Only about 10% of patients reported any dizziness, and it's a major factor seen in superior canal dehiscence, with 82% of patients reporting that in our series. Ear fullness is another one that mimics this pattern, where ear fullness is a relatively rare condition seen in otosclerosis, but very common in superior canal dehiscence, reaching about 60% of the patients. The reported hearing loss is interesting, I think, because in patients with otosclerosis, they notice their hearing loss, and they come in because they want to, have it repaired or figure out what's going on, or maybe they're wearing hearing aids or wondering about it. It's fascinating to me that the number of patients who have airborne gaps due to superior canal dehiscence don't really report hearing loss. So they're not coming in because of hearing loss, and you're detecting this very often. They're usually coming in for other reasons. So that's just interestingly. Decreased sound tolerance was low in both groups. However, autophony, as you would expect, is much greater in the superior canal dehiscence group and quite rare in the stapes group. We looked at the rate of acoustic reflex testing being done at the time of the first audiogram, and in our otosclerosis patients, it was only done 1/3 of the time. In our superior canal dehiscence patients, it was done closer to 50% of the time, and that may have been driven by the physician actually going back and asking for that testing to be done because they were concerned about the superior canal dehiscence symptoms. But it was concerning to me that even in my own institution where we are clued into this issue, only 1/3 of the time were we getting acoustic reflexes. Of course, VEMP is used to help diagnose superior canal dehiscence, and we don't use that in otosclerosis patients very much. CT scans were done much more commonly for superior canal dehiscence patients as we were trying to confirm this diagnosis. And as has been my habit throughout my career, very rarely am I doing it in straightforward patients with otosclerosis, but maybe that's changing. So we ran this through a model to see, well, what would be most predictive for distinguishing otosclerosis from superior canal dehiscence. We looked at the acoustic reflex testing in particular, and then we looked at the number of historical factors that you can get during the history to see how predictive it would be. And we looked at the area under the curve and the Breyer score, which is just a test for how accurate the test would be for predicting the outcome. The lower the Breyer score, the more predictive and the more accurate it is, and the higher the area under the curve would predict greater accuracy as well. And so what we see is that acoustic reflexes have a very low Breyer score and a high area under the curve, and very high sensitivity and specificity. So in fact, acoustic reflex testing in our data confirmed and predicted the diagnosis. It's just that we're not doing it enough to be sure that we don't miss something. But also, interestingly and hopefully, in a hopeful way, if you ask the questions about pulsatile tinnitus, sound and pressure-induced vertigo, ear fullness, then once you reach 3 of those things being positive, you do get a very strong predictive value for distinguishing superior canal dehiscence from otosclerosis. So not all airborne gaps are otosclerosis. An incorrect diagnosis is still a concern. It still happens in the United States many times where patients get otosclerosis surgery for airborne gaps that are due to superior canal dehiscence. It ends up being lawsuits. I've seen several of these, so it's something we should be watching out for. Our data suggests that you maybe should take a little bit more history than you normally would for your patient with otosclerosis. And if they have 3 or more of the typical superior canal dehiscence symptoms, and the acoustic reflex tests are present or absent, These are reliable ways to distinguish superior canal dehiscence from otosclerosis. As I mentioned, my concern is that we're not doing acoustic reflex testing enough, and this is partly due, I think, to the fact that historically in the audiology field, acoustic reflex testing was done for a retrocochlear analysis of the hearing loss, and we simply, as physicians and otologists, we don't use it for that anymore because we have MRIs that are readily available to us and more accurate. But our colleagues in the audiology field still practice this retrocochlear idea. So they're doing acoustic reflex testing for sensory neural hearing loss or asymmetric sensory neural hearing loss, but they're not doing it when there is a airborne gap. So I would encourage everyone to work with their audiologist in their clinic to be sure that they're being consistently done, because it could save you having a misdiagnosis and a missed surgery. And I'd also would suggest that you don't go to the operating room unless you have an acoustic reflex test on your patient or a CAT scan prior to doing the procedure. It does bring up the question, when you start to do more CAT scans, though, you're going to start to see more superior canal dehiscence along with your otosclerosis. And so this is, I think, a new dilemma that we're not sure exactly how to manage. But the patient who has concurrent otosclerosis and superior canal dehiscence. And this would present with a normal tympanogram. The acoustic reflexes would be absent because they have otosclerosis. And the vent responses, at least the acoustical vent responses, would likely be absent because of the stapes fixation. You might be able to do bone conduction vents, but those are not readily available. So the question is what do you do for these patients? So if you do stapes surgery, it can result in hearing improvement, and that's what the literature supports. But interestingly, it's never complete closure of the airborne gap. So it would be an important counseling piece to say that you might get hearing improvement, but it would be only partial. But the more concerning thing is that latent superior canal dehiscence symptoms can be unmasked by your stapedectomy. So all of a sudden you do your stapedectomy and now they have autophony and they have ear fullness and they have pulsatile tinnitus. And so that would not be a very happy patient. And this is just an example of a patient that I showed you with improvement in the airborne gap but not complete. The data out there to suggest that we can do surgery safely is very small. There's only really 3 reasonable studies, but only 20 patients in one study, 5 patients in one, and 10 in the other. And the results were very mixed. There are examples of profound hearing loss, unmasking of superior canal dehiscence, and like I mentioned, persisting conductive hearing loss. So the success rate in these patients definitely is lower, and you're taking on some extra risks, which might mean additional counseling. So it's painful, I think, because when you see an audiogram like this, you're thinking that you're going to be able to help this patient with a procedure that's been tried and true for a long time, and we enjoy doing it because of the good outcomes. But if the patient has a superior canal dehiscence at the same time, it does require a different type of counseling or stronger consideration of use of a hearing aid. And I think over time we'll figure out whether or not it's a safe thing to do and how often it's safe. When I present this slide to most people, it's a very mixed response. Some surgeons are going to walk away from it. I presented this to 3 of the most experienced AP surgeons in the world, and they all walked away from it. They said that they weren't going to do it. But when I present this to my colleagues, it's very variable. Some are like, sure, I'll just counsel them and I'll do it. Others were, let's just use hearing aids. So it's just food for thought for all of you. Once again, Jack and Herb, thanks so much for having me down here. It's always good to be in Sarasota. What did you do? My question is what are you gonna do? Yeah. So I've only done 2 patients with that scenario, and both of them had unmasking of symptoms, and both of them had partial recoveries. And so I'm very cautious, but it's 2 patients that I've personally done. I'm also I'm very suspicious of chart reviews from our clinics, even though I just gave you a chart review, but it had a lot of patients in it. So I'm uncertain. I think it's really a counseling piece, but you can influence the patient on how you counsel them, no doubt. So I definitely would say, let's fit that hearing aid for sure and make sure that it's not working fine for you. If it's not, then you could go down that path.
I would never not defend somebody who did something like this. Like you said, there's already lawsuits happening, or
Yeah.
lawsuits for not giving acoustic reflexing and not knowing if it's
Yeah.
making the patient better or making the patient have a dead ear.
Yeah, I mean, if you have the incorrect diagnosis, they may not have otosclerosis at all, right? That's what the lawsuits are. So.
Well, it's very, now to throw another controversial thing here. Now, Neil Nyack is going to talk about round window reinforcement for superior canal dehiscence. And maybe you do your stapedectomy and do the round window reinforcement, and everybody's happy.
Yeah, there's combinations.
So thank you for having me here. As he said, I am Neil Nyack. I am number 46, and I'm currently actually practicing at the Silverstein Institute. But before I start, of course, big thank you to Dr. Silverstein. Thank you so much, for your contributions to the field of ENT, but also obviously your training and guidance during my fellowship year, for the fun and the training and the teaching we had in the OR and in the clinic. And I just want to say it's truly inspiring to have someone like you that's in our field that's constantly innovating. Even now, every couple of weeks in the clinic, he'll come up to me with another idea. Like he's still coming up with new ideas. It's just very inspiring, and I think we're very lucky to have you in the field. So today I'll be talking about round window reinforcement for superior canal dehiscence. And Dr. Cass already spoke about this in depth about the symptoms. I'll go over it briefly. So as we know, superior canal dehiscence can present with a variety of symptoms that can range from just slightly bothersome to debilitating, including autophony, bone conduction hyperacusis, pulsatile tinnitus, pressure-induced vertigo, and hearing loss. And these symptoms can all be explained by this dehiscence. So on the left image is normal. On the right image, you can see there's a superior canal dehiscence. There's a couple other dehiscences on there, but the top is the superior canal dehiscence. So it's all due to this third window phenomenon that occurs. So there are 2 natural windows into the bony labyrinth, the oval and the round window, as we know. And the superior canal dehiscence essentially creates this third window effect, similar to a perilymphatic fistula. So this dehiscence actually presents this new low impedance pathway for pressure that's entering at the oval window to dissipate through the labyrinth instead of the cochlea. So when we look at air conduction, some of the energy is lost through the dehiscence, which is why we get the conductive loss, but also that canal can be stimulated, which is why we get that pressure-induced vertigo and the characteristic nystagmus in the plane of that canal. And then when we look at bone conduction, bone-conducted sounds can actually enter the cochlea through the dehiscence, which is why we get that bone conduction hyperacusis. So in terms of treatment, the most common way that this is treated is through canal plugging and resurfacing or capping. And the 2 approaches for this are middle fossa and transmastoid superior canal repair. And while they are effective, they can carry significant morbidity and may not be suitable in older patients. And being here in Sarasota, Florida, it's kind of always something in the back of our minds. Round window reinforcement may represent an ideal option for initial surgical management in patients who do not desire or are unable to have more invasive surgery. So, of course, one of the first people that looked into this was Dr. Silverstein. In 2009, presented the first case report of a patient that was treated with superior canal dehiscence. It was a 37-year-old male who had all the classic symptoms, and he underwent a 3-layer closure of the round window, first with cartilage, then with bone wax, and then with perichondrium. And the patient actually had resolution of all of the symptoms after that, basically indicating that this is a procedure that could work. A few more patients were done the same way, and the same results were not replicated. And so the decision was kind of made to proceed with more of a reinforcement instead of a closure of the round window. So 5 years later, there was a multi-center case series, Dennis Poe's in here as well, and it was a retrospective review that looked at the severity of the superior canal symptoms pre-op and post-op. And there was actually statistically significant decrease in almost all of the symptoms. So the autophony, bone conduction sensitivity, pulsatile tinnitus, the dizziness with loud sounds, oral fullness and balance all improved. The one thing that did not improve was the hearing loss, and that kind of makes sense from a pathophysiology standpoint, that air can still go out through that dehiscence. You're not really affecting the dehiscence itself. You're closing that round window. So this is the way that we do it here at Silverstein Institute. This is the way that it was taught to me in fellowship and kind of how I've continued to do it. So this is a transcanal approach surgery. So after you kind of set up, the first thing that we're going to do is obtain the tragus perichondrium, a typical posterior incision on the tragus. You only need to get about 1 by 1 centimeters. And then what you can do is take a 2-millimeter punch biopsy and just put it perpendicular right through the tragus cartilage, and you'll get this really nice cylinder of tragus cartilage that comes out. The next step is to raise a tympanomeatal flap normally. Visualize a round window niche. Sometimes it's anterior enough that you don't need to drill, but sometimes it is posterior, and a little bit of drilling is necessary. After visualizing the round window, you want to assess morphology, remove any adhesions, which can commonly be over the niche, and then go ahead and insert that plug into the round window niche. And the idea is not to push it in, pack it in too hard that it's deforming the window or putting pressure on the window. The idea is to kind of have it be snug, but kind of just sitting on the window itself. The next step is to put the graft over the cartilage plug to kind of bolster it in place, and then we cover it with gel foam for a multi-layer closure. So this is a picture here. This is the left ear, overall normal-looking middle ear, and you can see the round window as indicated, the round window niche as indicated by the arrow. Before doing this, you can scratch the promontory a little bit. Some bleeding may help with the healing postoperatively. And then after you've done that, you can go ahead and put your plug in. And one thing that I've noticed by doing these more and more is that sometimes when you try to put that 2-millimeter plug in, it doesn't fit nicely. It kind of like moves around and kind of like bobbles in and out. One thing you can do is actually slice the cartilage, make it about half as thin, and then you'll notice it actually fits in a lot nicer, and I've started doing that more often. And after you put that cartilage in, then you put the perichondrium on top of that, and then followed by that, you put some gel foam on top of that as well. So what I did want to present was a most recent case series we've done over the past 5 years. It was a retrospective review, and we noticed anecdotally that there may have been some differences in the preoperative testing and with the results for patients that were maybe more overweight than less, and also differences in age we kind of wanted to look at. So we did look at these groups separately. But in terms of outcomes, we looked at the Glasgow benefit inventory. We looked at symptomatic improvement over short and long-term follow-up, as well as post-op audiograms. And so this is a retrospective review before and after surgery at different time follow-ups. And the symptoms that we assessed were ringing tinnitus, autophony, pulsatile tinnitus, subjective reduction in hearing, dizziness, and oral fullness. And we also did the postoperative GBI survey at follow-up. So we had a total of 21 ears done in about 18 patients. It was about 50-50 split between male and female. It was average age of about 60 years of age, and the BMI on average was about 28. We didn't really see a difference in terms of the two BMI groups that we had done. When we looked at CVEMPs, approximately 50% of patients had that characteristic lower CVEMP threshold. We didn't really find any differences between the age groups or the weight groups. About 33% of our patients had suprathreshold bone lines, something that can also be seen with the superior canal dehiscence. And most commonly, the audiologic presentation we had was a moderate mixed hearing loss. In terms of preoperative symptom presentation, the most common symptoms were subjective hearing loss, as well as tinnitus and oral fullness. And again, between these two groups, we actually didn't notice much of a difference between the two groups. So the most kind of salient data that we have from this presentation was the rates of symptomatic improvement that we assessed at long-term follow-up for all years, and the average follow-up was about 3.2 years. So you can see actually across all of the outcome measures that we had, the tinnitus, autophony, pulsatile tinnitus, dizziness, subjective hearing loss, and oral fullness, there were some numeric decreases, and two of them did reach statistical significance. Dizziness, which was about a 63% reduction, as well as oral fullness, about a 56% reduction in that symptom. When we did the the Glasgow Benefit Inventory results, we had about an 89% response rate. 10 out of the 19 patients, about 53%, indicated a positive change to health status, and we didn't notice any difference between those groups that I'd mentioned earlier, the weight groups or the age groups. When we looked at the post-op audio testing, out of 21 ears operated on, there was about a 15 to 20 dB drop in the high-frequency bone lines for 4 patients, so about 19%, we did notice a drop there. And out of those two didn't notice it, 2 felt symptomatic, and they ended up getting hearing aids, and they're doing well with that. 1 patient did actually have increased hypersensitivity in sound after surgery, despite a stable post-op audiogram for unclear reason. And the other audiograms were stable for the remainder of the patients in the study, and there were no real major complications reported. So in conclusion, round window reinforcement for superior canal dehiscence is a viable option, especially in patients that are not suitable for or do not want more invasive surgery. We did find some statistically significant reduction in symptoms of dizziness and oral fullness. And patients with these symptoms, they may represent ideal candidates for round window closure. And as shown, previous literature and others has shown improvement in autophony, pressure-induced vertigo, pulsatile tinnitus, and bone conduction hypersensitivity as well. So hearing loss is the one symptom that's not expected to improve following the surgery. So I think the point that I kind of want to bring home about round window reinforcement surgery is that you really could consider this as an initial option for the treatment of superior canal dehiscence. Doing the procedure doesn't necessarily burn your bridges to do the other one. So if you do the round window reinforcement and it fails for whatever reason, those other options, the middle cranial fossa or the transmastoid approaches, they're still there. And as Dr. Cass pointed out, a lot of these patients actually don't come to you for the hearing loss. They actually come to you because of the pressure-induced dizziness. They come to you because of the fullness or the autophony. And so doing a relatively simple procedure, just lifting up a flap, putting some cartilage in there, may actually resolve the reason they came in here. But obviously, you do want to discuss with them that improving the hearing is not really a goal of the round window surgery. And so when I first heard about this surgery, in residency, I was just, of course, like with anything on the newer side, always have a level of skepticism. But I think the thing that really brought it home was we did a case in fellowship where this woman had had autophony, pressure-induced vertigo for about 3 years, and I think she worked in the entertainment industry, and she couldn't do anything around speakers. We did the surgery. 2 hours later, I just saw her in the post-op unit to see how she's doing, and she's like, it's gone. She's like, it's totally gone. All my symptoms are resolved. And of course, at the time, I was like, well, you just had surgery, there's anesthesia, there's packing in the ear, there's blood products, whatever. 1 month later, she's like, it's still gone. Still gone. And I think to this day, she's doing pretty well. So I think there's definitely therapeutic benefit to have to this procedure. It's relatively simple, low morbidity, and really could be considered as an initial option for a lot of patients. References. Thank you.
Thank you, Neil. I want to thank all the speakers for sticking to the schedule. We're all on time. I've never been at a conference that is so on time. Although we started late, we caught up. If there are any burning questions to discuss, let's do that. We could spend 5 minutes before we eat. And if otherwise, when we go out, please, please, please stop by the exhibitors because they've come to support the course, and we could not have a course like this without the support of the industry. And two, in here there will be a talk during the lunchtime from Cochlear and from Earlens about their respective products. We have one question from Dennis Poe.
Yeah, a great talk. Thanks. If you're